Greetings. My name is Tracy Mitchell. I'm a registered respiratory therapist, a certified asthma educator, and an environmental protection specialist at the United States Environmental Protection Agency in Washington, D.C. I work in the Indoor Environments Division, Center for Asthma in Schools, where we support community-based champions across the country working to help children with asthma breathe better in healthier indoor environments. I'd like to welcome you today to our webinar. The United States EPA sponsors today's webinar, and we will explore partnerships between healthcare and weatherization as one model for addressing the indoor environmental determinants of health. This is our third in a series of 3 webinars to discuss solutions for indoor environmental determinants of health, and you'll hear more about the first 2. Our featured speaker today is Michael Kent, and I'll be introducing him in just a moment. First, if we could go to the next slide, I'd like to welcome all of our participants. For the next hour or so, we'll be hearing from Michael about his program at Contra Costa County Health in California. And then we'll look forward to a discussion period for about 30 minutes after Michael's presentation. And we'll talk a little bit more about that in just a second. So let's meet our audience. If you could go to the next slide. So we've had almost 700 registrants for this webinar. Very excited about people's interest. It really speaks to the need for this information and the work that's happening all over the country. So you'll notice in this map, the darker the state, the more registrants and participants we have. So what's striking to me is there's actually only a few states that remain white without any participation. So we're very excited that all of you could be with us today. And so on the next slide, we'd like to hear from you, and we'd like you to just take part in our poll. So if you wouldn't mind, as we begin, please take part and answer. We want to know how knowledgeable you're feeling about this information as you come into this discussion. So the information about partnering healthcare and weatherization to address the indoor environmental determinants of health. We'll repeat this poll at the end, so please participate, and so that we can measure how we're doing and meeting our learning objectives. Please select one of the options there and let us know how you're feeling about this information and where you are today. While you're selecting your answer, I just would like to tell you we'll be using the chat function today and on the webinar interface to collect your questions throughout the presentation. So all participants will be muted, but you do have the opportunity to ask questions or share your thoughts and comments in the chat section. And as I said, after Michael's presentation, we'll be hearing those comments and answering those questions in our discussion. Finally, as you complete the poll, I'd like to remind you that today's session is being recorded and will be made available on AsthmaCommunityNetwork.org. Hopefully all of you are members, but if you're not, please join so that you'll be able to access this webinar as well as other resources. So we'll give it just another few seconds. Hopefully you've all had an opportunity to select one of the options here. And let's go ahead and close the poll. So it looks like the vast majority of participants know a little, but are really interested in learning more. So I'm very excited you're here today. You're going to learn a lot. Many of you don't know much about bridging healthcare and weatherization. And it sounds like we have a pretty nice representation of folks who maybe are already doing this and connecting this work. Welcome, everyone. There's going to be something for you to learn no matter where you are in this process. Go ahead and go to the next slide, please. So as I stated, This is a final series in a 3-part series on solutions any community or state can apply to address the indoor environmental determinants of health to improve asthma outcomes. Before I introduce Michael, I just want to spend a few minutes to talk about EPA's work in the indoor environments division. I mentioned I work on a team at EPA that develops and promotes the into practice proven solutions for the indoor environmental determinants of health in clinical care, public health, and home and energy services. And we're eager to host Michael and spotlight Contra Costa's story today, as EPA has actually been involved with Contra Costa for many years. We've kind of been involved in the background through national partnerships. For many years, EPA provided support through grants with the Green and Healthy Homes Initiative and the Regional Asthma Management and Prevention Program to provide technical assistance to Contra Costa. And you're going to hear a little bit about that work in Michael's story today. At the Indoor Environments Division, we build capacity with communities like Contra Costa to help them put the key drivers of high-performing asthma programs in place. Those key drivers are what you see on the right hand of this slide, and it reflects some of our learning over the past 20 years. So at EPA, what we've learned in our federal mission to promote environmental asthma management as a standard is that when cross-sector leaders and champions across programs within a community deliver asthma care through collaborations and partnerships to integrate the community and clinic in asthma care with strong ties to populations that are most affected by asthma, tailored environmental interventions can reach the children who need them most, and high-quality asthma care results. Asthma comes under control, and kids can breathe easier everywhere they spend their time, particularly in their homes. We have seen that when communities assemble these key drivers and make high-quality asthma care systems possible, they're not only possible, but they run efficiently and effectively. Another way to say this is asthma systems improve outcomes with environmental management when they break down silos. That's a core message you're going to hear today and a core message in this graphic. The solutions we want to spotlight are the learning about what it takes to break down those silos to implement care that can reach the right children where they need it and how they need it in the community. The next slide. So in the Indoor Environments Division, we've studied high-quality asthma care systems like the Contra Costa model for more than 20 years. Through our national awards program and national webinars, we shine a spotlight on excellence so all communities can learn from and adapt their own versions of what works. As we've promoted these silo-breaking systems for getting community-based environmental care to the children who most need it, we've uncovered frameworks for the social determinants of health, those conditions that affect health and quality of life, including the physical environment. We have technical solutions for an entire subset of those social determinants of health, the indoor environmental determinants of health, or IEDOH. IEDOH are modifiable environmental factors such as household air pollution, mold and moisture, presence of pests, chemicals, and other irritants. Those factors influence risk and the experience of chronic disease. And as you'll hear today in the story behind Contra Costa's model for partnering asthma healthcare with weatherization, breaking down silos is the key to why this picture is not only a social determinants of health model, but a model for reimagining healthcare, climate resilience, and equity by addressing IEDOH. Next slide. The Indoor Environments solution, the Indoor Environments helps communities to build cross-sector systems to address IEDOH in asthma disparities. because that is the lens that focuses us on the critical role of in-home environmental interventions in asthma care. Today, as we host stakeholders from across the country and across sectors, including healthcare, energy services, housing, and healthy homes, built environments, clinical asthma care, and healthcare financing and policy. All these sectors are represented today. We want all of you, each one of you, to hear that, one, there are proven technical solutions for indoor environmental determinants of health in asthma that communities can use and benefit from. And two, partnerships between healthcare and community services, particularly weatherization, to address IEDOH and asthma are model solutions for high quality asthma care, for the social determinants in healthcare, and for health equity. Next slide. Today, we focus on one community that's been building a cross-sector model at healthcare and weatherization to address IEDOH and asthma for many years. I mentioned our previous two webinars in this series. The first one looked at innovation in financing in California Medicaid for asthma home visits with environmental interventions. In the second webinar, the use of population health data and analytics to identify where in a community's housing stock the IEDOH are contributing most significantly to poorly controlled asthma. Today, in our third webinar, we focus on building from those Medicaid investments and health analytics insights to deliver remediation services for IEDOH to bring cross-sector partners in alignment around health risks in homes. We will build out these resources and related materials to the webinars on AsthmaCommunityNetwork.org. So as I mentioned before, if you're not a member, please take time to join so you'll have access to these and many other resources. EPA has been supporting Asthma Community Network since 2008, and with over 1,000 member asthma programs, there's a great deal to share and learn there. As I mentioned before, this is also where this webinar will be archived. So now, as I turn to welcome our speaker, you can go to the next slide, Michael Kent. I want to encourage you all to listen for how and why building this cross-sector model in Contra Costa became and remained a priority for program leaders who have plugged away for many, many years to build capacity to partner weatherization services with asthma healthcare. Listen to all the silo breaking that Michael, his partners, and stakeholders have done, and you'll hear it takes time. It takes time and certain soft skills that these champions have stayed at over time because they recognize the very real need to address the home environment as a non-clinical driver of health outcomes, especially for low-income people in their community. Listen particularly for how climate concerns, indoor exposures, health equity, and severe asthma intersect in this work, and how those ideas together are part of what keeps these champions working to build out more support and capacity to deliver a comprehensive model to mitigate IEDOH and climate risks that they encounter during their home visits. Please remember to use the chat function throughout the presentation. Send us your questions and comments during the presentation. And when our speaker Michael's finished, our contractor Kate Hastings, who will be monitoring the questions as they come in, will facilitate a discussion with Michael and myself to address all of your concerns, questions, comments, etc. So without further ado, I'd like to introduce Michael Kent, who we're thrilled to have with us today. Michael is the Hazardous Materials Ombudsman for Contra Costa County, California. He's been there for the past 24 years. He responds to concerns and serves as a resource on environmental pollution issues for county residents. Michael also staffs the county's Hazard Materials Commission, an advisory board to the County Board of Supervisors. He also provides support to the Public Health Department on issues of environmental justice, air pollution, asthma, and climate change. Michael previously worked for two nonprofit environmental advocacy organizations and was a pollution prevention specialist for the Thurston County Health Department in Olympia, Washington. Michael's received his bachelor's degree of philosophy and interdisciplinary studies from Miami University in Oxford, Ohio, and his master's of environmental studies from Evergreen State College in Olympia, Washington. I'm thrilled to have Michael here with me today, and I'd like you all to welcome Michael as he begins to tell us his story of Contra Costa County, California.
Okay, well, thank you for that great introduction. And it's great to see so many people around the country interested in this topic. Again, my name is Michael Kent with the Contra Costa Health Services. My job today, I guess, is to make sense of this very long and complicated title to my presentation and to share with you our experiences in trying to implement our program here in Contra Costa County. But first, let me say just a word about the county health department here. We're a fully integrated health department. That is, in addition to having a hospital and a number of health clinics around the county, and the public health department, environmental health, hazardous materials, mental health departments that we have. We also have our own health plan that serves most of the Medi-Cal patients in Contra Costa County. And that's going to be important a little bit later on in my story. But with that, let me start, next slide, please, by introducing Contra Costa County. But before I do, let me just say, I have three main messages to you that I am going to put out throughout my presentation. And I'll come back to this at the end of the presentation. And those are: know which way are north, follow your passions, and get out of your silo and make friends. And like I say, we'll come back to that at the end of my presentation. And hopefully I will have convinced you that these are important takeaways for this kind of work. So next slide. So Contra Costa County, for those that don't know, is in the San Francisco Bay Area. We're just across the bay from San Francisco and north of Oakland. We have a population of about 1 million people, and it's very diverse in terms of race, 43% white, about 26% Latino, 18% Asian, and about 10% African American. It's also very diverse geographically and in terms of the weather. The west side being mostly a Mediterranean climate along the bay, and the east side being more like the Central Valley of California, where in the summer you could be 15 to 20 degrees warmer than it is on the west side of the county. So a very diverse county geographically and in terms of population, but also you can see in the next slide, it's also very diverse in terms of its environmental impacts. This map, the sort of ugly orange areas, are what we call our disadvantaged communities. And that's a designation under California's system of ranking and evaluating census tracts for their impacts, environmental impacts, especially related to environmental justice. And so those areas are the census tracts in the state that have the top worst scores in terms of environmental impacts, in terms of environmental justice. And so you can see it's not evenly spread throughout the county. Our shoreline areas from west to east are the areas where we have the most impacts. And this is where we have 4 oil refineries, a number of chemical plants, and a number of power plants. And that makes sense when you think that these are the areas where you can bring ships in to move product in and out. These areas are also where the majority of our rail lines and pipelines are that serve those facilities. And pay special attention to this map and this sort of distribution of where these environmental justice communities are. because you'll see that it's a common theme that runs throughout my presentation. Next slide, please. So when I think about climate change and public health, and this gets at my first point about true north, this is how we in the health department think about climate change. And that is, the impacts of climate change are going to disproportionately impact vulnerable populations who are already suffering health inequities. So everything we do around climate change is focused with this lens in mind, that we're trying to address those vulnerable populations who are already have disproportionately poor health outcomes. Next slide, please. So probably starting around 2010, our public health department decided we really needed to work on the issue of climate change, because we believe, as does most of the public health community, that climate change is going to be one of the biggest threats to public health we've ever faced. And so in 2015, we published a vulnerability assessment of our county with a CDC brace grant support that focused on heat. And why we focused on heat was because heat was something that was already impacting our county. Just a few years earlier, we had a major heat wave, which sent a lot more people to the hospital than we normally see going for heat. And so it was a problem that we were already having that we knew was going to get worse based on predictions around climate change. Next slide, please. So about that same time, I had my own home insulated through a rebate program from our energy company, because I live in Alameda, which is on the bay, and it doesn't get very hot there, so most homes don't have air conditioning there, but most homes also don't have any insulation in them and weren't built with that in mind. And so I had my home insulated in about 2013. But even before that, I was really interested in the topic. So I had been tracking my gas usage over time. And you can see, and I won't go into this in detail, but you can see in my baseline from 2004 to 2007, I was using 655 therms of gas a year. When I put in a new furnace to replace my 30-year-old furnace, gas furnace, that dropped significantly. And then in 2013, when I fully insulated my home, it dropped again for a total reduction of my gas usage over time of 56%. And what I saw at the time, that saved me about $40 a month in my gas bill, which would be about twice as much now, because gas prices have actually almost doubled in California in the last couple of years. But in addition to saving me money on my gas bill, I noticed a lot of other things when I insulated my home. Next slide, please. I noticed there was a lot of health benefits actually from doing that. So one thing that I already mentioned is that and I mentioned in terms of a concern of ours in Contra Costa County, is that it keeps homes cooler. Like I said, I don't have air conditioning, and it doesn't get very hot where I live very often. But sometimes, 2 or 3 times a year in the summer, it could get up to 95 degrees. And I noticed that in the morning, if I shut my shutters and kept my doors and windows closed during the day, even though by the end of the day it might be 95 degrees outside, after I insulated my home, it only got up to like 78 inside. And that's a significant difference in terms of being vulnerable to the impacts of heat. Like I said, I noticed it saved money, about $40 a month for me. But to be honest, that's not a whole lot of money for me. I always used to be spending that kind of money every month at Starbucks. But if for somebody who's low income or on a fixed income, that's a lot of money a month. That could be the difference between being able to pay your energy bill that month or being able to buy the food and medicine and other essentials that you need or not. So that's a significant cost savings for somebody who's low income. I also noticed that when I went to change my air filter after that, it was much cleaner than it had been before, because instead of pulling air in from every crack and crevice in my home, it was recirculating through the house and through my air filter like it was supposed to. And so when I changed my filter, it was much cleaner. And of course, that's a real benefit for people who have respiratory problems and even other health problems. And then finally, insulating a home can help keep out moisture in the form of condensations forming on outside walls, especially if there's furniture in front of them. And it can also help with ventilation and keeping indoor moisture levels down from using your shower in your bathroom or cooking in your kitchen. So I saw all these various health benefits of weatherization. Next slide, please. But especially the heat and the ability to keep my house cool even though when it was hot. And so we started thinking, well, okay, how can we operationalize this at the health department? How can I take that knowledge? And this kind of gets to that question of follow your passion. So I was really jazzed about, what I learned from insulating in my own home. I said, how can we do something about that at the health department? Because, we don't go out and insulate homes. We don't, work on infrastructure really. So we kicked around a few ideas until we finally settled on a project working with our public health nurses. Because in the health department, we have a public health nursing program that goes to people's homes to, that were referred to them by their doctors to work on their health issues with them in their home. And we thought, well, those public health nurses could be our eyes and ears in the community and can find for us patients who really could benefit from weatherization. And then it just so happened during my research to figure out how to address heat and for our community, I found out that we had a low-income weatherization program in our building department. Now, in some counties in California, our weatherization programs are run by nonprofit groups, but in our county, it's out of our building department. And so I went to them and I said, look, if I could bring to you a bunch of clients who are really medically vulnerable and could really benefit from your weatherization program, would you be interested? And the program manager, much to my delight and to her credit, said, yeah, because right now we really don't feel like we're utilizing our program as best we could. And then I went to our public health nursing program and I said, look, how many of you knew that there's a free program for low-income residents that can make improvements to their home that can improve their health? And this could be available to your clients. And not a single one of them were aware of that program. And so I said, well, would you like to be trained on it and help us enroll people in that program? And they were really enthusiastic about that. And so we did some cross training, so they knew about the program. We also developed some screening questions for them. So when they went into people's homes, they can ask them these questions, things like, is it too hot or too cold in the winter? Do you have problems paying your energy bill? And if they found clients they thought that could really benefit from a weatherization program, they referred them over to weatherization. And then I freed up some of my time to help their clients fill out the applications because, like many federal applications, they're somewhat complicated and take a lot of time and are somewhat cumbersome. And, we thought that for a lot of low-income people who were already sick, that filling out a bunch of forms, even though in the long run it might benefit them, was not something they were necessarily going to do. And that proved out to be actually true. And so ultimately, we had 32 referrals from 17 different nurses, and we got 8 of those referrals completely through the process. And there was a lot of reasons why we didn't get more through, mainly because people were either afraid to ask their landlord for permission, because most of the people we worked with were renters, or landlords didn't want us coming in and making modifications to their programs. But we figured that program was successful enough to continue with it. And RAMP, that was mentioned in the introduction, Regional Asthma Management and Prevention, got some funding from our state health department to write up a case study of that work. But before I go on to talk about what we did next, I'd like to step back and talk a little bit about the social determinants of health. Next slide, please. Because that's a term that we say a lot, and in the introduction, they talked about the social determinants of health, and it kind of rolls off the tongue really nicely. But what does it really mean? And I want to take a second just to talk about that using an example that happened to me personally. But this is a illustration of the social determinants of health put out by the Bay Area Regional Health Inequities Initiative, which is a collaboration of all the public health departments in the Bay Area addressing health inequities. And this framework kind of illustrates what we mean when we talk about the social determinants of health. And it talks about it in terms of upstream services and downstream services. And the downstream services are the things that most of us think about as healthcare, that is treatment of diseases in a medical setting. So you get sick and you go to the doctor or the hospital and they either treat you or they don't. But in the public health arena, we know that upstream is where really people's health is affected. First in the areas of living condition, and that's where we work in terms of the physical environment, the home environment. But also even further upstream than that is the institutional inequities that people face. And then furthest upstream are the social inequities in terms of classism, racism, gender bias, and sexual orientation discrimination, and immigration status. And so I want to illustrate that with an encounter I had with one of the clients that I worked with. This was a gentleman who had been formerly homeless, and our public health nurses had found him a place to live out in East Contra Costa County, which I mentioned was like the Central Valley. And they found him a place in January, and it was a nice enough place, and he was doing fine until June, when they had the first really bad heat wave out there, and he ended up in the hospital with heat stroke. So they called me up and said, we think this client could really benefit from getting some weatherization and especially air conditioning, which we could provide. And so I went to his home and I met him, and he greeted me at the door, and I met this man who appeared to me to be about 10 or 15 years older than me. And he was in really, really bad physical condition. He was on oxygen. He was bent over because he had really bad back problems. And, but, we went in, we started to get some information from him and talking to him. And it struck me that he had many of the same health problems that I do. He has asthma, and I have asthma. He has chronic back problems, and unfortunately, I have chronic back problems. And he had diabetes, and I have diabetes. But I noticed, I'm reasonably healthy, fully functioning person, and he looked like he was in horrible shape. And then we started talking some more, and I realized he, in fact, wasn't 10 or 15 years older than me, but he was actually a couple months younger than me. And that really made me start to think about, well, why is this? Why is, even though we have the same health conditions and the same age, he appears to be in much worse shape than me. And then I started thinking about our backgrounds. I'm white, he was black. I grew up in a pretty solidly middle-class home and got a good education. I've always had stable housing and stable employment. He grew up very low income. He barely got out of high school, he told me. He had spent time in and out of jail over his life. He had been previously homeless. And all those things that we call the social determinants of health, all those living condition differences between he and I realized, those were some of the things that made me, at that point, be in relatively good health, and him be in relatively poor health. And so that really struck to me what we mean when we say the social determinants of health. And that was really important to me. And it really drove home to me, why we were doing that work. And I think, again, that gets to my point about you need to be passionate about your work. So, but let's move on to the next slide. So about the same time that we finished up this pilot and decided we want to continue this work, I found out, really just through serendipity, that there was a program being offered by the Green and Healthy Homes Initiative with the support of EPA to help cities and counties develop business plans to do asthma in-home trigger assessments programs. And of course, asthma was one of the conditions that our public health nurses were going out to work with their patients about, and one of the reasons they referred people to us. And this is a map of Contra Costa County, the red areas being the areas of high asthma rates. And again, you'll notice it was very similar to our areas where we had, disadvantaged communities through an environmental justice lens along the waterfront. And so we thought, well, does that fit into what our mission is? And, is that our true north? And we felt like it was, because we realized doing weatherization for asthma patients, the kind of health benefits that it provides can really help asthma patients. So we applied, next slide please, for this grant. It was a technical assistance grant from GHHI, but we realized we needed to broaden our partnership. So now, instead of working with the public health nurses, we partner with our health plan, because as I mentioned before, they serve our Medi-Cal patients in the county, and they were able to place a public health nurse and a community health worker in their quality improvement group that could do work with us. So we partner with them, but on the energy efficiency side, not only did we partner with our low-income weatherization program in our building department, what we call our Department of Conservation and Development, but we also partner with some local programs that provided energy efficiency services. We partnered with a local alternative energy provider called MCE, who had a rebate program that low-income residents could be eligible for. And we partnered with a program called BayREN, the Bay Area Regional Energy Network. That was also operated out of our Department of Conservation and Development. They also provide rebates for energy efficiency improvements with funding from the state California Energy Commission. So with those partners, we applied for a grant from GHHI, next slide please, for a business plan, technical assistance grant. And we got that in 2018 and spent about a year working on this business plan, which essentially showed that if we were to provide these asthma in-home trigger assessment, education, and mitigations, along with energy efficiency improvements, that within a 5-year period, we could pay for that program with avoided emergency room and hospitalization visits for the health plan. Of course, there are a lot of other benefits to preventing asthma attacks, but those are the two most obvious and most cost-saving immediately. And then GHHI had another round of grants available, a phase 2 technical assistance grant, to help us try to find funding for that effort. And at the time, we were really interested in figuring out what the feasibility of integrating that kind of work into our Medi-Cal system, what nationally you call Medicaid, because that would be a stable, institutionalized source of funding for this type of work. So we were really interested in seeing if we can make that happen. And about that same time, the state of California was considering legislation that would have enabled Medi-Cal to pay for that kind of work. For a lot of reasons, that didn't happen, but the state legislature did set aside $15 million to set up pilot programs around the state to do this kind of work, so they could sort of proof of concept to hopefully then eventually pass that kind of legislation that would enable Medi-Cal to pay for that kind of work. So we applied for that grant, and it was through the Sierra Health Foundation, who the state contracted with to implement that grant. But unique to the 28 original grantees, we were the only one that partnered energy efficiency improvements with the asthma mitigation work. And so next slide, please. We began that work 3 years ago, and our local air district was so interested in our model because they were interested in improving indoor air quality and electrification of gas appliances, that they provided us with a supplemental grant to help augment that work. Since then, we got a second grant from the Air District, the Bay Area Air Quality Management District, to provide that same kind of model to homes within 1,000 feet of freeways. And the reason it's restricted to that is because that came from a penalty against VW for faking their emissions data. And so there has to be a nexus to transportation pollution. And so our second grant limits us to doing work near freeways and other transportation sources. We also coincidentally got another grant from EPA to provide two of our local federally qualified health clinics funding to do asthma mitigation and education in homes that they serve, but there wasn't enough funding to do the energy efficiency component, but at least they're out there doing energy or asthma mitigation work. So we began that work 3 years ago. Next slide, please. And this is kind of the model that we have. So we recruit our clients in our first initial visits with a community health worker in our health plan. They go out, do an intake, collect information from the client, do some baseline monitoring, do some asthma education, asthma trigger education, and then they refer the case to a group called AEA, the Association of Energy Affordability. And the reason we're working with them is they're also basically I would call them the general contractor for two of the other programs we work with, MCE and BayREN. They implement the programs for them. So we thought, hey, they'd be great to work with us as well. And so they're one of our partners as well. And then they go out and do an energy efficiency and asthma trigger assessment at the home. And then they develop a scope of work for that home for figuring out what that home needs, both in terms of asthma trigger mitigations and energy efficiency improvements. And then they determine which out of our various programs and sources of funding we use to get that work done. And then once they're completed with all that work, they have a bevy of contractors that they use to do that work. Then our community health worker goes back out, does a third visit, follow up to see how things are going. They deliver supplies to the client, things like green cleaning supplies, mattress and pillow covers, storage containers. We provide them with HEPA vacuum cleaners and air purifiers. And then they go out, do another evaluation, so we can do a sort of a before and after comparison. And then they do a fourth visit farther out even to see how their health is doing. And that's essentially our model. Next slide, please. This is just a little bit more detail about it. In terms of how we get our clients, it's turned out we've gotten most of them from referrals from doctors in our system. Because like I said, we're a fully integrated health department. And so, our health plan provides insurance to the Medi-Cal clients who are seen primarily by our own doctors. So it's very easy for us to get referrals from our doctors. But we also can get lists of all the people who've been to the hospital or ED for asthma in the last month. And so we can cold call them and say essentially, hey, we saw that you had to go to the hospital for your asthma last month. Would you be interested in a program? It's totally free, but could help you improve your asthma and reduce your asthma triggers. We're still getting referrals from our public health nurses. And then our county weatherization program and AEA can also refer clients that they're working with that they get from other sources to us. But really, it's been primarily through doctor referral. We've also sent out letters to all the clients that we know in our health plan records that have severe asthma. That was about 600 letters we sent out, and that's been getting us some pretty good returns lately as well. Then, like I said, we can actually do referrals for more clinical care if clients need them. And it turns out most of our clients haven't needed that. They've gotten pretty much the clinical care that they've needed. And then, like I say, we do a first visit with our community health worker. And when they need support, we have a public health nurse there that can support them. Our second home visit over time changed a little bit because it's a little thing called the pandemic. Obviously, we had to move to doing virtual site visits initially. And it turned out it was good to do that site visit virtually and in person, especially to the energy efficiency assessment. That had to be in person. So that delayed our project a bit, but we realized having both a virtual and in-person visit kind of helped in that first virtual visit helped establish a rapport with the client, helped figure out who really needed the energy efficiency in-person audit and who maybe didn't. And so it not only improved efficiency of our system, but it enabled us to build better rapport with our clients. Then, like I say, after AAA did their site visit and developed the scope of work, they figured out who that work would go to, whether it be county weatherization or one of our other programs. And one of the things we found out over time is it really made sense if we wanted to do work with clients to get that permission from the landlord before we even went out and did the home assessment, because it still is very hard to get a lot of landlords to agree to let us do our work. And it didn't make sense to go out and do the home visit and the assessment only to find out later that the landlord wasn't going to let us go out there. Next slide, please. So next steps for us in terms of our model is trying to integrate this into Medi-Cal, because since the program started, the state decided there was enough evidence to go ahead and make changes to Medi-Cal that enable us to pay for asthma mitigations with Medi-Cal funding. They're allowing a $7,500 lifetime per client spending on asthma trigger mitigations. They also made some changes to Medi-Cal that can make the asthma education and outreach part Medi-Cal reimbursable. So most of the managed care organizations around the state are contracting with third parties to provide that work. We haven't figured out how that's going to work for us yet, but whoever we contract with for that third party, then we want to be able for them to be able to partner with AEA or our Department of Conservation and Development or some combination of that to continue this partnership. So that's going to be the next step for us, is to figure out how to continue this partnership working through Medi-Cal instead of through grants. Next slide. So let me wrap up and get back to my takeaways and see if they make a little more sense to you now. So first one, knowing which way is north. And what I mean by that, I was an Eagle Scout. My son was an Eagle Scout. I was very involved with his Boy Scout troop. And when Scouts advance in rank, you have a board of review, which is really just to talk with the Scouts about what they learned during that rank. And tradition for our troop was to always ask at the end of their board of review, ask the Scout, point to which way is north. And we do that because, well, Scouts are supposed to know map and compass, but it's also a metaphorical thing to do to sort of say, you got to know which way you're headed. You got to have some goals and direction to really be able to succeed. And I think that's really true for this kind of work as well. You got to know what it is your focus is, because there'll be lots of temptations to get off track by either because there's some grant out there that you might be able to apply for, or somebody else wants you to do something else. And so I think it's really important to know why you're doing what you're doing. For public health departments, it's to address social inequities and the social determinants of health for vulnerable populations. Other organizations have their own true north. That doesn't mean you can't be flexible, but it does mean you need to know why you're doing what you're doing. And then, like I said, follow your passions. I developed a real personal interest in this, which is why I was willing to go out and try to create a new program, because it's hard. Making partnerships is hard, applying for grants is hard, doing innovative things is hard. I mean, just for us to figure out how to provide HIPAA compliant data or HIPAA protected data in a HIPAA compliant way between the health plan and our energy efficiency contractors was really hard. So, if you're not passionate about this work, it's not gonna work out. And also, the people you partner with, unless there are partners in those organizations who are equally as passionate and want to be champions for that partnership, it's not going to work unless you have really, really strong top-down direction from your organization that you're going to have to do this. Without that, it's going to be the line level staff that are really going to make these programs successful or not. And they just have to be passionate and be champions for that work if you're going to try something new and different and out of the box. And that's my third message, which is when you're addressing a complicated disease like asthma that has many reasons why people have asthma attacks, both social, economic, and physical, or if you're addressing something like climate change, which is multifaceted, no one agency, no one mission is going to be able to take care of it. You're going to have to make partners. You're going to have to get out of your silo. I know that's difficult because most silos come with dedicated funding to do dedicated things and are somewhat inflexible, but you just have to do that. And the best way to do that, I think, is kind of like what I did, is just get out and meet people. Pick up the phone, talk to people, say, hey, here's an idea we have. Here's how we think it might fit into what your mission is, as well as benefit us. Let's see if we can get some synergy. Let's see if we can do work together to do something good that neither of us could do alone. So those are my takeaways from the work that we've done. I hope this has been helpful to you in some way, and I really look forward to our discussion. Thank you very much.
Great, thank you, Michael. Wow, what a wonderful story you tell. I really appreciate the personal stories that told us, and really added to the work that you're doing, to why this is such important work. I heard, as I said in my opening as well, the need to break down silos, to champion in new ways, find ways of working together. And I heard what you said, that even when people are want to be collaborative and want to coordinate effort, it takes time. So thank you for sharing that experience. Thank you for candidly discussing the process, what it looks like, what it feels like, the challenges associated with it, and how you've been able to overcome those challenges and continue to work towards implementing these programs. So right now, I think we'll invite Kate to join us. Kate's been monitoring the chat and the questions and comments that have been coming in throughout the last almost hour. Kate, are you there?
I am. Hopefully you are there. Can you see me? Can you hear me? Hi.
Yes, welcome.
Hi, thank you so much. Michael, thank you so much. That was just a terrific presentation. Thank you. And we did have questions pouring in. And it's so nice to see so many names I recognize in the questioners. It's really good to have all of you here. We heard from the National Energy Lab in Alaska. We heard from CHW Solutions in Minnesota. We've heard from Florida. We're hearing from all over the country with more questions than I'll have time to get in for you. But let me ask you first a really specific question, and then I'm going to ask you a really broad question. The first specific question I want to share is a bunch of our audience is listening and saying, wow, this is impressive. And they're curious about what are the sort of, if you can, Michael, just average types of costs for remediation in a given house. And if you could share, and you may not have the data yet, but there was some interest in like, what kind of asthma triggers are you finding most commonly? And what do you see in terms of asthma outcomes when you address them? So average cost per house, average contaminant encountered, and if you can, average outcomes that you see. Anecdotal is great. After intervention. And I'll start with that one for both of you, but Michael, you first, please.
Yeah, so in terms of, let's see, break down the numbers. In terms of supplies that we're providing to people, I'd say we're providing about $500 worth in total. We're actually getting our portable air purifiers for free from the Air District, so that's nice. The grant we have from the state allows us to spend up to $1,000 per home on minor to moderate remediations. So about 500 of that is in supplies. And then but the amount we're spending per home really varies depending on what they have need done. Some homes, we're just giving them supplies and they don't want anything else. One of the things we've done is to contract for deep cleanings of homes, which costs a couple $100, and we think maybe about 40 of our clients will want that for their homes. And then in terms of actually getting in and doing physical work, it really varies from around $2,000 up to $10,000 or $12,000. I know our weatherization program averages about $5,000 to $7,000 per home that they serve, and that's labor and the work. And that's not including the cost of the assessment. That's just the actual work. So that's really all the details I can give at this point. But it really just varies. Somebody who needs their home insulated and their windows replaced, obviously going to cost a lot more than just somebody that might need their carpet cleaned up. And we kind of have an informal cap. If somebody has $50,000 worth of mold damage in their home, we're not going to do that. We just don't have the funding for that. In terms of, what are the asthma triggers we're seeing? Honestly, I don't know. That's not something that I'm keeping. All the work that we do, that the community health worker does, goes into our clients' electronic medical records. And I'm sure that's something then they can search for. Again, that's another advantage of us being part of our health plan, is that it's paired with their electronic medical records. And so not only can we put data in there, but their doctors can see everything that we've done for them as well. But the way we primarily evaluate success, we do something called the asthma control test, both before and after. And we've definitely so far, this is anecdotal because we haven't tallied up the numbers completely, but we definitely see improvements in our asthma control test scores. And then just hospitalization or ED avoidance. And so far, we've seen that. But that's a measure you have to measure over time. But right now, I think that's pretty much as I can say.
Thank you. And a related question, and you may not be able to answer this one either, but there's a curiosity about what kind of budget would you guess you got from the health department to kind of operationalize this work? That's a tricky, I realize you've built this over time in your role, but there are other folks at health departments across the country listening. I imagine they're wondering, if I pitch to my boss, I want to do something like this, what's my budget like? That's something you can give us any idea about?
Well, that's a tough one because, well, originally, I can tell you what we originally proposed to the Sierra Health Foundation was we said we would do 150 clients over 3 years for $527,000. And I'm not sure what that works out to per client, but it might seem like a lot. But if you look at it that way, think about how much you could save by avoiding one visit to the hospital. You avoid 2 visits and you've clearly paid for yourself. But it's been kind of tough. That's one of the things we want to evaluate. But of course, we did this during the pandemic. And so that really changed a lot of things. We had to basically shut down our program for a while because our weatherization programs couldn't go into people's homes to do any work. We also lost our community health worker about halfway through the program. And if you work for a health system, you know that during the pandemic it was very hard to find help. A lot of people were leaving the health field because of burnout and other reasons. And it took us basically 6 months to retrain or to hire and retrain a community health worker. And so then we spent the next 3 months just catching up with the clients that we had kind of left hanging when she left. So, right now, I think like we're operating on all cylinders and being very efficient. And, I think we're going to try to look at sort of our production right now to estimate what a steady state, budget would be. But I don't have good firm numbers, but that's something we're certainly wanting to think about moving forward. And certainly something we have to think about for Medi-Cal, because for people to contract with managed care organizations to provide this service, it's going to have to be cost effective. And so that's something that I think everyone in the state is figuring out now, just how much to bill for this kind of work. So that's going to be an ongoing process for a while.
That's a very thoughtful and helpful answer, and leads us into another question. And I know this is a tricky one, but there are a lot of people in this audience who are watching California. And as you've said, the Medi-Cal program there is pretty progressive by comparison in this new benefit of the $7,500 per member per lifetime for home modifications. And someone is asking, in our audience, what are the limitations and what kind of supplies can that $7,500 be used for? I'm going to put that question to you, though I know you're going to say, well, we're still figuring that out, but let's talk about that a little bit. We know it's social determinants of health. We know home modifications, they listed some items, but where do you think that money's going to end up being okayed, Michael? Because this is, you're proving the pilot out there.
So the way the Medi-Cal program works is the referring doctor has to approve any changes. So they have to feel that they're tied to asthma trigger abatement or reduction. So I certainly think the kind of supplies that we've been providing are clearly that, addressing mold, addressing, dirty carpeting, definitely that. It might take some education on the part of doctors to understand that insulating a home is actually an asthma mitigation measure. Now, will it pay for upgrading old knob and tubing wiring so that you can provide insulation over it to, reduce asthma triggers? That I don't know. It might pay for tobacco cessation work. It might pay for anything that a doctor feels is an asthma mitigation reduction, removing old carpeting, I think, some minor mold remediation, certainly. Will it pay to fix the leaky plumbing that's causing the mold problem? I don't know. That's going to have to be a discussion down the line with, the doctors and the healthcare agency. If you have a leaky roof, if you have high humidity, certainly ventilation, I think, and from some of the great work that's been done by Dr. John Balmes and others in California around indoor air quality, particulate matter coming from gas stove and other combustion sources. Certainly, I hope replacing gas appliances and providing at least vent hoods for stoves will be eligible. So that could shoot the whole budget right there, right? Now, will they provide the upgrade to the electrical panel that's needed to put in an electric induction stove? I don't know. So those are some of the problems that we're facing, is that a lot of asthma trigger mitigations require other things along with them that the state may not consider asthma trigger mitigations. And then, what do we do about that?
Yeah, that's a really interesting answer. And as I'm listening to you, I heard a couple of things there. One, which I hope everybody in the field listening right now will keep a focus on, is that we have to do some more education of doctors, right? So that they understand what some indoor air interventions can deliver. I think we're going to need to think about that, as these referrals do need to have some quality assurance and quality control. I'm thinking of the person who asked about what will that $7,500 go for, and some innovations that that she has pioneered in her community, where, for example, community health workers, they have a medical director who just issues standing orders there's a standing order that these CHWs can do this work when they encounter an asthma patient. So it's like the pre-referral's already there. That's just an innovation that I'm thinking about, Megan, as you asked that question and Michael answered, and we think about the clinicians. So all of us, let's embrace that work ahead of us, which is to keep sharing why these interventions are so good with our clinical partners. Michael, you point out that this policy it's a moving target. It's a new policy, and everybody has got to figure out what's going to get approved and what's not. And there's a whole bunch of people in that system. A lot of those folks are represented on this call today. So This isn't like one and done. You get this going in your state and you're finished. I think then we keep going to figure out what are the best packages of indoor environmental interventions we can deliver. And as Michael said, and so many of you in this call know, you might encounter a house and only have enough money to do a little something when the whole house is what we all know we want to do. We have a lot of building to do to get there. Michael, there's so many questions, and a couple of them are, how do I learn more about Contra Costa? How do I learn more about Michael Kent? Can I have his email address? And you put your email address in the slides, so folks will be writing you. But just so you know that the audience would love to learn more. While I have a minute to toggle over, is there anywhere you want to tell folks they can learn more about you, or anything you want us to put up in the chat for folks to learn more about Contra Costa? And while you answer, I'm going to toggle over to see the 30 more questions that just came in.
Well, the pilot we did with our public health nurses, I think, is on the RAMP website. I can send people our vulnerability assessment. It's a little out of date now, but things haven't changed that much. In our business plan that we did almost 5 years ago now, 4 years ago. At some point, we'll write up the work that we've done for the Sierra Health Foundation grant. It looks like it's going to end this summer. We just got a no-cost extension to go to the end of October. So the summer is when we plan to write that work up. But yeah, and people can reach out to me. That's fine.
Thank you. There are a couple questions about air filters. If you're providing them, how are they funded?
Yeah, so like I said, in California, there are local air districts who regulate point source pollution, and the state air board does mostly the mobile sources. But our regional air district, the Bay Area Air Quality Management District, which serves the 9-county Bay Area, they've gotten funding to provide us with portable air purifiers, room size air purifiers, and one replacement filter. Because don't forget, these air purifiers, the filter has to be changed periodically. And if you don't do that, they can end up, causing more problems than they're worth. And for a low-income person, these things cost $40, $50, I think. That's a lot of money to be putting into changing your air purifier filter. As it is, most of us probably don't change the air filter on our furnace as often as we're supposed to. So they provide us with one air purifier and a filter. Out of our funding from the Sierra Health Foundation grant, we provide them with a second filter. So we give them at least 2 filters and the portable air purifier. That is about $200 worth of stuff. The Air District gives us a choice. So there's a range of air purifiers out there. And RAMP, I think, has on their website, somebody has developed sort of these low-cost air purifiers you can make yourself out of a furnace filter using like a MERV 13 filter in a cardboard box. And somewhere on the internet, there's directions on how to do that because a lot of people simply can't afford portable air purifiers. But so we get those free from the Air District. Otherwise, we'd be paying for them out of our Sierra Health Foundation.
And Kate, I'll just jump in. EPA has information on their website about air purifiers, and I believe there's some information on there about actually, making these box fans or things. So please, use EPA resources as well. And I'll make an offer to Michael. Any of the resources that folks are asking for that you're able and willing to share, we can get them posted on Asthma Community Network for you, and it'll be one-stop shopping for folks to be able to access those resources.
Thank you.
Michael, there's a couple of questions, and I wonder if you can explore this because everyone struggles with this as they try to find these community clinic home visiting partnerships. And it's this HIPAA compliance issue. And you mentioned that you had encountered some HIPAA compliance. You mentioned that maybe some of the information folks were interested in was behind that HIPAA wall in the EHR. Can you tell us just a little bit about what kind of HIPAA compliance issues you encountered, and especially when you found ways to remove them from being barriers? How'd you do that?
Well, you can't remove HIPAA compliance because it's something we take very, very seriously, but you can work within it. So just for folks that don't know, that means personal information of medical clients, our medical clients, our health Medi-Cal clients, is protected. We can't share that just willy-nilly. That's their name, their address, anything about them. Even just the fact that they have asthma, I can't share with anybody, let alone their specific case conditions. So, but we have to share information with AEA to so they can go and do an assessment of the client. So we ask clients for permission, and with that permission slip, that solves part of the problem. But we still have to transfer data from us to them. And so California, and I don't know what the rules are nationally, but in California, there's something called a business associate. And if they have that status, then you're allowed to share HIPAA compliant information with them. But the way you share it still has to be HIPAA compliant. And because we're a big health department, like I say, Contra Costa is 1 million people. So I think we have 3,000 employees at our health department approximately. Our contract, our license with Microsoft 365 enables us to have a SharePoint system that's HIPAA compliant. And so we share data with them through Microsoft 365 through a HIPAA compliant portal. And we only share the information that they absolutely need, the name, address, phone number, and the name of the client, et cetera. We don't share anything that we don't absolutely have to share. So even when we report information to the Air District under our contract with them, we can't, because they're not part of that business agreement, we can't share individualized data with them. Everything has to be aggregated. And we're fortunate, because we're an integrated health department, that these clients, I'm part of the health department, so I can share this information within the health department. Our community health worker works for the health plan, so she can get that information from our electronic medical records. But like contrast that other counties I know, even the public health department is separate from the managed care organization, so they don't have that same level of access. They have to get those patients referred, with the permission of the client. Once the client gives permission for you to share that information, then it's okay. But get it in writing.
Thank you. Thank you for explaining it for folks, and also for explaining the difference between your health department and what some others might experience. I think that's really helpful. This is a big area that we're all learning in, so thank you. There are some questions about how long after your intervention are you administering the asthma control test? And for folks who are asking for the details of that asthma control test, you can search for that online, the asthma control test with all caps. It's a, I don't know if it's trademarked, but it's an official thing that Michael's referring to there. What's your lag time there, Michael, between intervention and ACT assessment follow-up?
Ideally, a month, but we haven't been working in the ideal world. So a lot of clients, it's been much longer, which is actually, okay. Towards the end of the project, we may have to squeeze a little. Those last few clients we serve might have to be a little less than a month. But ideally it would be a month. And then we do another follow-up phone survey with some other questions that the state health department has asked us to ask to get even further out data. And that usually happens ideally, again, 2 weeks after the third follow-up visit.
And there was a question about, this is an interesting question that's probably at the intersection of all of our lives here. When you're doing this work with focusing on folks who are affected by severe asthma, somebody in our audience is describing that they know, at least 50% of the severe asthmatic pediatric patients they encounter are exposed to vaping and smoke and other sort of behaviorally driven contaminants. And there's just a question about how and where do those kind of triggers and potential in-home solutions for them come up in your work Anything you
Yeah.
can offer?
Well, certainly that's something that our community health worker talks to either the client or the child about. We serve pediatric and adults, but they'll talk to them about that. We have tobacco cessation, referrals we can do for them. We've bought some clients smoking jackets so they can go outside and smoke outside and leave the jacket outside and not bring the smoke back in. That's not ideal, but it's better than them smoking in the house with their kids there. We're lucky in California. We have pretty progressive tobacco rules. There's a lot of counties or a lot of cities in our county where people are not supposed to smoke in apartment buildings because that's a big problem for people in apartments. Their neighbors are smoking and it drifts into their units. So most of the cities in our county have pretty aggressive tobacco prevention ordinances. But yeah, it's a big part of it for sure. And I grew up with a dad who smoked a pipe, and I know firsthand what that's like. It's just something we try to stress to them, but we don't. I mean, we can't require them to stop.
Right. And relatedly, there's a question about the level of education for occupants and parents, assuming that we're thinking of a home visit around a pediatric asthma patient. I think this question is just wondering, what about health literacy and issues around that you might be able to shed some light on based on your experience with your population?
Yeah, so we use educational materials that we've borrowed from RAMP and from Alameda County. We use the asthma knowledge test, I think they call it, where they test people's knowledge about asthma. Our community health workers right now, we're fortunate, both speak Spanish. But if we don't, we've encountered people in languages that besides English and Spanish, and we have a translation service that we can use to bring them in to translate for us or interpret, I should say, during a visit. So we work really hard on trying to make sure that the materials are at the right level. We talk to them about everything from asthma triggers to how to use their spacers properly, about the different medications and what they're for, the difference between a rescue inhaler and long-term acting steroids. We talk to them about having an asthma management plan. In our health plan, all clients are supposed to have an asthma management plan. We're finding not everyone does, and so if they don't, we work with them on and notify their doctor that they should develop an asthma management plan that they're supposed to do with their doctors. So we do all that in our first visit, and then reinforce it then in our third visit.
Thank you. And for anyone who's looking for multilingual and multi-education level materials around triggers in the home that are associated with asthma, I just want to give a real plug for you to go to US EPA's website. I remember making terrific materials over the years with the Indoor Environments Division that are specially designed to educate children and multilingual parents and people of all literacy levels about indoor triggers in the home. Michael,
thanks, Kate. And I was just going to say, and I'll make a quick plug, as Michael broke down silos and working with different organizations at the community level, at EPA, at the national level, we're doing just that as well with our HUD partners, our CDC colleagues, our NIH colleagues. So we have materials that are co-branded, that were developed by multiple agencies. I'd encourage people to look for those materials as well.
Yeah, I'll just to add on to that, didn't mention it anywhere else, but there is a whole lot of money coming out, I understand, through the Inflation Reduction Act for energy efficiency improvements. HUD has a lot of money out now to do work around home mitigations in addition to lead mitigations for lead poisoning prevention programs. I mean, our ultimate goal is to kind of have a healthy homes program where we can address all kinds of different in-home health issues, spill and fall prevention, asbestos, asthma, lead, water conservation, Ethan. So there's all those different partnerships out there that we've been exploring. But again, you got to find those champions in those programs who are willing to work with you, because it's not easy.
Thinking about those champions and champions unusual, we might have to pull into our, like, this grand work we all share together, because everybody on this call knows this is going to take all of us. You said you sometimes encounter landlord resistance to even having an assessment done, much less getting beyond an assessment. Folks on in our audience, they're wondering what kind of resistance and why are landlords resistant? And let's talk for a minute about this, because we're going to have to figure out how to make landlords partners in this before we get the whole house done, right? So I'm really curious to hear you talk to all of us about that landlord partnership, which I don't think any of us are getting right quite yet. So what do you think, Michael?
No, I don't know that I have any good answers to it. I think that, some of the landlords just were like, I just don't want the government in my house, my property doing stuff, even though it's free and it's going to make it a more valuable piece of property. I think some of them are worried you're going to find code violations and report them to code enforcement. Honestly, it's something we haven't done, which we need to do better, is reach out to the various landlord associations. I'd like to partner more with tenant rights organizations who interact with landlords all the time and talk about how this can be a win-win for landlords. One thing about saving money on your energy bill, a big reason people get evicted is because they can't pay their energy bills. And, that can't help the bottom line for landlords when they have client turnover. So I think there's a lot of advantages for them to participate. I like to see us working more with code enforcement to, talk to landlords who might otherwise have to pay for some of this stuff themselves, to take advantage of these programs, if that makes sense. So, so I don't know all the reasons why landlords are reluctant, but we certainly face a lot of it. I think the code enforcement issue, that is something some have personally brought up to me, although, that's not really what we do, go in and look at code enforcement issues. But it is going to take a lot of work to make landlords understand the program and be comfortable with it, and to do it proactively. So it's not, when you have an individual client who you want to do work with, but it's something they hear about ahead of time. And I think just like with our public health nurses, the key to getting them all to agree to the program and to get involved, like I said, we eventually had 18 nurses in the first year and more since, is, once you get that first one who's done it and it's been successful for their client, you use them to talk to the other nurses about the program, because it means a whole lot more coming from one of their peers than it does from me. And I think it's going to be the same with landlords. You need to find a landlord who's had a good experience, and then get them out there talking to other landlords. And that's, I think, where you start making a difference. And then it just takes constant reinforcement, because people forget, they get busy, they got their own things going on. And so you have to have ways to keep reminding people about the program and about the benefits of it. But so far it's been a tough nut for us to crack, and taken up a lot of our time and resources, making multiple calls to landlords and, doing like I said, initially developing the scopes of work, then finding out the landlord wouldn't allow us to do the work. So, if we can solve that problem, it'll make the program go much more smoothly, for sure.
Thank you for focusing on that part of the conversation. I'm purposely thinking of all of the many people in your audience who may have opportunities to sort of initiate and build on those conversations around our field needs to build this connection to landlords, and we need to build the recognition of what's in it for all of us with some of the proactivity you pointed to. And when, this is a work in progress for sure. But thank you, Michael, for sharing with us a chance to look at what you're doing, how you're doing it, and to share so much of the real pieces of what it takes to put these partnerships together, and to convince folks to stick in it with us, because we share some true north here. the better we do at educating all the folks who share this Venn diagram with us, the sooner we're going to get to being able to deliver whole home solutions, which I just know everyone in our audience is really passionate about, because I think we all know these things work. There are so many of us with that personal story. It's how do we do it at scale? And that's why we have, I think, close to 600 or 700 people on this call thinking together about that and learning with you. It looks like folks have been dropping off now. They're getting ready to go to their next call, but we had a huge bunch of people show interest in this. And thank you, Michael, so much. Thank you, Tracy. And I'm just going to say bye now in my facilitation of questions and turn it over to you to close us out. Thank you.
Great, thank you. Hopefully my internet holds out for just a couple more minutes. I've had a little bit of glitchiness. But before we close, if we could pull up the poll, we've had the vast majority of participants stay with us through the discussion. So thank you for that. And so now please take just a moment before we close to answer the poll question. At the end of our presentation here, we'd like to know, were we successful? Were you able to learn a little bit today? Do you feel more confident, more comfortable? Do you have more ideas about partnerships? If you wouldn't mind, please do that. And as we're doing that, I'll just say thank you again to Michael for the amazing presentation, for his willingness to share the information and his experience with all of us. And I'm going to invite you to come back maybe next year, Michael, so you can give us an update on how things are going. I think folks would love to hear, what happens between now and then, and hopefully. So before we close, let's just take a quick look at our poll results.
Yes, we can see the poll results. We can see that there's almost no one saying, I do not know about bridging healthcare with weatherization after this terrific conversation. And we see, I know more than I did before, and I have ideas about partners, or I know how to connect healthcare with home modifications.
Okay, well, with that, yes. Okay, so well, thank you again. I just want to thank Michael, thank you, Kate, and thank you to our wonderful audience. With that, we will close the webinar. Have a great day.
Thank you. Bye-bye.
Bye-bye.